My goal for being your psychologist is to get myself laid off.
But I feel like they haven't been as dramatic as some of the technological things that we're looking at with social media and AI.
One of my quips that I say a lot is, if we could talk ourselves out of depression or anxiety, I wouldn't have a job.
To start with a fun fact for you that's going to lead us into our topic. Did you know that the human brain weighs about 3 pounds? And for something so small, it really is one of the most extraordinary parts of the human body. It creates every memory you've ever had, every emotion you've ever felt. It helps you to navigate thousands of tiny and big decisions all day long, every single day. And for something so complex, we often expect it to heal when there's a problem or an injury on sheer willpower alone. And I think it's time we started rethinking the importance of our mind and our mental health, which is our topic today. Now, I do think things have gotten better over the last few years, but let's face it, there's still a lot of stigma out there when it comes to being diagnosed with a mental health condition and needing treatment. And here's the thing: depression, anxiety, trauma, other mental health conditions, these are not rare struggles anymore. The chances are high that you know someone who's been diagnosed with something. Maybe it is a friend, a family member, a coworker, or maybe even yourself. And we are going to talk about that today too. Why are we seeing such a rise in behavioral health diagnoses? I mean, is it that we're getting better at diagnosing things? Are we overdiagnosing? Is there something larger at play in our society? And here's some good news. The way that we understand mental health and its treatment has dramatically changed over the years. We still do the things where we talk about our past and we take a medication, but there are some really promising new approaches out there that help people process their mental health conditions in new and exciting ways that help them to move forward after years of feeling stuck in their disease process. So my guest today is going to talk to us about some of these newer, exciting therapies. We have with us today Dr. Katie McBride. She is a licensed clinical psychologist. She has her PhD. She has over 25 years of experience treating a variety of mental health conditions, and she has also served in various director roles in professional organizations in her field. She has also helped with organizations that are committed to helping individuals and families to get through divorce, and not just get through it, but to get beyond it and to thrive. But what I think is the most fascinating thing about her is, as I was alluding to earlier, some of her experience with these newer, cutting-edge, evidence-based therapies that we're going to talk about today. And I'm sure you've heard of some of them. There's the EMDR, that's the thing with the eye movements, Brainspotting, trauma center, trauma sensitive yoga, and something called developmental needs meeting strategy. So we'll talk to her about all of these. So whether you are here struggling with something yourself, or you are helping a family member, or maybe you're just simply curious about some of the new developments in modern day psychology, I think this is going to be a fascinating topic you'll want to stick around for. Guys, please help me welcome Dr. Katie McBride to the show. Hey, how are you doing?
I'm good, Shelley. Thank you for having me.
Good to be. I'm glad you're here. Yeah.
I love talking about psychotherapy and the mental health conditions, like you said, because they are so common across us. So yes, we're seeing rising levels of diagnosed depression and diagnosed anxiety, especially in the last 6 to 10 years, really.
Yeah.
And with a real uptick since COVID. That's kind of splashing the news. But depression and anxiety are normal parts of life as well. And it's really the stuckness that leads us to need extra help. But they're experiences that are important for us to have in order to cope and to move forward in our lives even.
Okay, that's an interesting point.
Yeah.
Yeah, so tell us, when does it cross over into becoming just a normal part of life and becoming something that is really a mental health condition that you need to go get treatment
sort
for.
of a diagnosable kind of clinical
Sure.
level condition. So a lot of times, like within diagnostic frameworks like the DSM, that's the Diagnostic Statistical Manual, that is one frame of diagnosis that's probably the most commonly known. You think about things like depression as anything over 2 weeks can be a rule of thumb. Now, do you have to wait till, for that to happen in order to seek help or support? No. Do most people experience that for much longer than that? Yes. But that's kind of a good rule of thumb to think about if things are really, really stuck.
Okay.
And you just can't get out of it. One of my quips that I say a lot is, if we could talk ourselves out of depression or anxiety, I wouldn't have a job, because we spend a lot of time when we're starting to struggle with something, starting to feel very heavy and down, kind of hopeless and helpless to make any change, sort of struggling with worry that just can't quit, no matter how much we sort of know in the sort of top of our brains that this is fine. This is not as big of a thing as my body is telling me that it is. That we can't talk ourselves out of it, because it's not contained just in our sort of top of our brain, our thinking brain.
Okay.
It's contained in our emotional system and in our whole nervous system in our body.
Right.
Yeah. And so we have to find ways of accessing kind of all of those systems in order to make sustainable change. And one of those ways is to do psychotherapy. Yeah.
Right. So I am curious, before we get into treatments, about, yes, what is exactly going on in your brain when you're having these episodes, if it's depression or anxiety or, say, trauma? I know you do a lot of work with trauma too.
Yeah, that is so I can do a general overview more.
Sure, yeah, absolutely.
Right.
Yeah.
So the stuckness has to do with patterns in our brains, in our systems that get stuck, that can't kind of get moving from one point to another point. So there are a lot of systems in the brain that are involved with any of those diagnoses. But you think, there's a lot of talk, medically, you can speak to this more, but the serotonin systems are involved.
Right.
And dopamine systems, or reward systems in our brains. A lot of the attentional, depression and anxiety and trauma that are very linked, which we'll get into in a moment.
Okay.
But all of those affect our concentration abilities, our own ability to assess ourselves realistically, to engage in relationships in a sort of predictable way.
Right.
So there can be a lot of avoidance and lack of initiative and motivation. There can be a lot of agitation with any of those kinds of presentations too.
Right.
So our nervous systems are either overactivated essentially or underactivated. And all of that's definitely a common thread across what you're talking about with depression and anxiety and trauma. Okay. Those are in diagnostic frameworks like the DSM and things that are required for insurance purposes. Yeah. They have these separated categories. But when we're really looking at, and the more they look at inside the brain and with functional MRIs and things like that, and inside the body, and then just even as kind of who shows up in my office, they're very, very connected. So you may have, one sort of can fuel the other. When you have chronic conditions, whether that's a post-traumatic experience, set of symptoms, whether that's a chronic anxiety, like generalized anxiety or panic disorder, whether that's dysthymic disorder, which is kind of chronic, quote unquote, low-level depression, or major depressive disorders. Any of those chronic kinds of problems create a sense of despair when you can't get better, right? It creates and exacerbates that same sense of helplessness and hopelessness.
Right.
Sort of giving up. What's the point, right? Those quote unquote word symptoms, when you start thinking that everything's pointless.
Right.
The worthlessness is that's definitely even a category underneath depression.
Sure.
A sense of worthlessness, a sense of lack of motivation. Again, if there's no point, I'm too messed up to be helped.
So I have a question about something you just said. I guess, well, two things that you just said really that stuck out to me. And so I'll say I'll say them both. The first one is, does it generally start with a deficiency of things like serotonin, norepinephrine, dopamine? Is that where it starts? And then maybe it moves to like other parts of your body are affected? That's one question. And the second question is, I did want to ask you a little bit about what you were talking about, functional MRIs. So let's go with the first one, the chemicals.
So when I was first, I think even just back in graduate school, there was this whole idea I would get asked all the time. I'm asked less now.
Yeah.
Is this a chemical imbalance? But bottom line is, our experiences directly impact our neurochemistry.
Okay.
Right? As I'm speaking versus as I'm quiet, my neurochemistry is shifting when I, lift my arm.
Okay.
Right.
Okay.
That requires a change. Right.
Yeah.
And the issue becomes when it becomes chronic. But the disentangling of what are the, I don't think it's quite a chicken and egg thing anymore.
Yeah.
It really is experience that goes all the way back to, you can even talk about prenatally. Experience goes all the way back through our lives and fuels some of these patterns of, for example, attachment. So we're sort of shifting a little bit, but all this is very relevant. So if we have secure attachment, and that means when we have a sense of safety and security as an infant, before our nervous systems are even developing.
Right.
If we have a sense of secure attachment that this person is loving, caring, and safe, and my needs are being met consistently, then my neurochemistry and my whole nervous system that is not developed when I'm born, it's developing, it's co-regulating. That's a word too, right? It's co-regulating and learning how to regulate itself. So co-regulating with my caregiver. If I have consistent attachment and needs met, then my regulation system is going to look very different, because it's going to, I have a need, I'm hungry, and then my need is met, and then I can settle. So that's getting into sort of the sympathetic nervous system kind of activating, like signaling that we have a need to be met. If that's met, then my parasympathetic nervous system can activate and come in and make this nice little rhythmic sort of sign, right? Sign rhythm.
Okay.
If, on the other hand, way in the beginning of our early existence, I don't have secure attachment, I have a parent who is struggling in one way or the other, my needs are being met inconsistently or rarely, right? So now my sympathetic nervous system signals to my body that I need to be fed or changed or cooled or warmed or settled in some way.
Right.
But that need is not met. So instead of having this nice like activation, need met, deactivation, all of a sudden now I've got activation that stays highly activated.
Okay.
Maybe eventually getting the need met. Maybe not.
Okay.
And then we get into real struggles, because now we've got this infant who does eventually regulate, but some of this system that's supposed to signal our needs gets it's either not developed very well at all, or it's kind of unpredictable.
Is this like how so does it, like, say in those instances, like with an infant, is their brain developing then around this, like in sort of a way that is not, I wouldn't call it normal, but like where it's functional? Like, is it developing in kind of a dysfunctional way?
Yeah.
And so then that just carries over into childhood, teen, adulthood.
100%. Yeah. Okay. Because then that affects the way that we perceive the world.
Yeah.
Right. And so our experiences are these lenses that we're looking through, I'm just using visual, but our sort of sensory lenses that we're perceiving what's, how predictable or not predictable is it? Mm-hmm. If something is very predictable, then I don't have to be hypervigilant to make sure that I know what's going to be happening, right?
Right.
But if something's very unpredictable, and yes, that is being developed, especially in the first year of life,
right?
Okay, then if it's unpredictable, I have to be more hypervigilant. That's just more aware of my surroundings. I've got to do that in order to detect any danger, for example, and really any time that it might be met, sort of seeking that out. And yes, that sets up those patterns that can lifelong. And so if we have, so that gets into some of the ways that we understand trauma too.
Okay.
So that may be shifting gears too quickly. But yes, these patterns can be set up. And that's some of why when I think some of the stigmatization around these diagnoses, around these struggles happens even within our own selves. We have such a negative, critical voice when we have these struggles. We're weak. We're not strong enough. You, in your intro, you talked about sheer willpower should be able to be enough. And then if it's not enough, that means there's something wrong with me.
Right.
Those are very powerful, persistent kind of messages that then reinforce those same issues. But yeah, so the good news about, when I'm talking about attachment, sometimes people feel initially afraid, oh no, then I'm not really messed up because there's no way I can get back to, I can't go rewind and fix that. But that's actually what we're talking about, because just like this secure attachment creates, might be strong, but certainly leads to those kinds of stuck patterns where, we can work through trauma symptoms of that. But that's how we can heal that. And heal could be kind of a hokey word in a way, but yeah, we can heal those patterns in secure relationships. So in a lay person kind of way, you can think about how we, when people have, or when we have a difficult, quote unquote, childhood, difficult relationships, in the past, when we have a secure, attuned, loving, compassionate, present, romantic relationship, for example, or other kinds of important, intimate relationships and friendships, that's healing. Right. That helps us feel more secure. All of a sudden, not all of a sudden, over time, we can settle and feel better, and then relate to the world differently. Oh, this is possible. Yeah. This kind of relationship is possible. And in good psychotherapeutic relationships, that's what the basis is. We're trying to establish a new pattern of being able to relate and to be related to by this other person. Right. Yeah.
Oh my gosh, I wish I had like a notepad here because I have so many questions. Okay. Let me just, and again, I'm just going, just questions from, I definitely want to talk about everything you just said. But I want to go back to a little bit just with this notion that for so many years we've been treating with these medications that are replenishing, serotonin and whatever, norepinephrine, and then other medications that we use like for anxiety and, like with benzodiazepines, like the old school Valium or the Klonopin nowadays.
Absolutely. Right.
And those forces with the chemicals, are those things that you are born with a tendency towards like having deficiencies of these? Or like you were saying, is this something that's set up in childhood, or say you go off to war and you have a traumatic experience when you are in the Middle East and all of a sudden there's this deficiency, or is there something in our life that's causing this? Like what's going on with that?
So I could quip and say yes.
Okay.
That's the short answer. But I really do think yes to all of the above. But one thing I maybe would be helpful to address.
Okay.
Medications of all those kinds that you just listed are very important because the bottom line is we are trying to shift that neurochemistry.
Okay.
Right? So, yes, those experiences impact our neurochemistry.
Any of that can affect
all of
it.
it. Okay. Of course, we come in with different tendencies,
right,
and come into the world.
Okay.
What has been interesting, I think, in the last 20 plus years is how much more. It's not just nature nurture as a balance thing. It's how much turns out to be quote unquote nurture. How much turns out to be experience impacting this.
Okay.
Even our genetics, like when you get into epigenetics,
right,
that gets into a whole other pretty fascinating field. That goes back a long way research wise, but that's what leads to some difficulties disentangling your question.
Okay.
So, are we born genetically with predispositions? That would certainly make sense. But then with these experiences, these traumatic experiences, which we might want to define that as well, with a parent, you now have this parent parenting from this maybe limited ability to form secure attachment, for example, because of their experience. And then that may lead to changes in neurochemistry for this and in the nervous system and brain in this developing child, for example.
Right.
So then you've got all of that together. Then you have this whole other thing called resiliency, where there's a whole field of resilience.
Right.
That why is it that some people can go through these difficult experiences, and come out this way,
right,
and other people come out this way,
right? Absolutely.
That is actually the field of the study of resilience is probably how I got to be in my field in the first place. Was just kind of that is a fascinating question. So when I'm I work with a lot of people with what's called complex trauma and very extreme forms of bad things, really bad things happening as very young people, to them. And it's important to anchor to it is, there's a book that I quote by Christine Couture, who's a very prominent psychologist in trauma. But it's not you, it's what happened to you. Right. And that is an accurate statement that these patterns of, you mentioned PTSD from combat, for example. That is from what's happening to you. It's actually the body and nervous system's ability, efforts to cope with this overwhelm. That's what's going on. And it just can't get out of it because trauma impacts your brain in a way that messes up the timestamp. It gets stored in the part of the brain that doesn't have a timestamp. And so the past is the present. That's how it's experienced, right? So that's I'm rambling a little bit because that's important even as we're talking about the ability to change.
Right.
It's important, that these experiences really do, and they're so overwhelming to any human body. This is what you're going to get, right? This is trying to destigmatize. This is not out of weakness. This is not out of, it's simply what a human body is designed to do in the face of overwhelming stress and distress. That, again, overwhelming means overwhelms the ability to cope.
Right.
Your coping resources at the time of the event.
Right.
Or events, right? So that's, and all of that can be worked with and helped. And that's sort of the big message here too.
And you were talking about earlier, I think I had that question about certain MRIs. Are there studies that, I know that's not something that we do every day when we go to the therapist or whatever, however people are getting their mental health. There's a lot of different ways these days, but are there studies that show that people's brains are functioning different? What do those look like?
Yes. Now, this is getting a little bit out of my lane. It's sort of like I've got lots and lots and lots of training, some of which is in my brain. But yes, that's actually one of the, functional MRI is where you're looking at real time imagery of the brain and what's happening when stimulus is happening. So when you're shown pictures of trauma, or you're invited or you're asked to recall your trauma. Okay. And that, yes, that is showing different parts of our brains that are not sort of lit up, quote unquote, not being activated, being shut down. Those are the more thinking, planning, executive functioning parts, actually, when you're activating unprocessed trauma. And emotional centers like the amygdala is that's being lit up. That's being very activated when you're recalling unprocessed trauma. And lower parts of our brain, much more that are again stuck. And when you don't have what's called the noticing brain online, you can't stop that alarm system, which is the emotional center, and the activation in your sympathetic nervous system, like get ready, all the hypervigilance, the blood flow that goes out to your limbs, away from your digestive functioning. Your thinking, planning shuts down, right? And adrenaline and cortisol, all that stuff floods. And and so when you have that's what's being shown, is even when people are recalling unprocessed trauma, that's what's happening here. And so how do we engage those parts of our brain in order? We've got to activate what is some of those earlier experiences of the trauma. We have to activate that while staying grounded and not feeling flooded. Right. That's the trick. And that's actually what some of the therapies that we'll talk about, what's making those effective. So we have to activate this difficult material while we are staying present and grounded as much as possible.
And yes, definitely I want to talk about those, what I think are just some really fascinating therapies that you've studied. And I think you're giving us such a good groundwork for how these things are tied into your mind is tied into your body, and how your body's reacting, and how there are ways to get in there and unwind it and fix it. And before we get to that, I do just want to say just briefly, so just generally, anxiety, depression, trauma, I think you and I had talked about this over the phone a little bit. There are some things that are similar with these diagnoses. Can you tell us a little bit more about that? And we also did touch on a little bit, why are we seeing more of these things being diagnosed these days?
So APA, that's American Psychological Association, I've been doing a survey. I think it's about 3,000 or something like that, 3,000 people. They've been doing a survey of kind of this mental health state of America. For, I think it was 2008, but I could be wrong about that. We can check that. Okay. And generally, that survey found over years of time a pretty steady rate of depression and anxiety. Until between 2016 and 2020. And we can smile about that. And and for the first time also during that period, and that's increased even since then, the state of the world, the uncertainty, the state of the world, that entered into like the top 10 of factors that people identify. But we went from a state that was under 10% of people that identified with, sort of qualified with depression and anxiety symptoms to, I think it's over 20%.
Oh, wow.
Now.
Okay.
Yeah, it's an oh, wow.
That's a lot of people.
It's an oh, wow.
This is
so since 2020. Yes, American Psychological Association. So since 2020, the COVID, since that point, that's when we see this giant jump, which makes all kinds of, intuitive sense here. But what's worrisome is just that we're still there. That we're still this, but that word uncertainty, I think, is the short answer to your question. this pervasive sense of uncertainty and not having an end point.
Mm-hmm.
That's what I think, that's a big piece of our sense of our experience of pain and stress actually has a lot to do with a sense of our own control over that pain and stress, and a sense of when the time, like an end point. And we don't have either one of those right now. I think
Why do we not have an end point? What do you mean?
Well, it's when is the state of the world going to return? I think there used to be more of a sense of there are cyclical patterns to things, not just politically, but just that's what is certainly coming into my office, and that's what some of the surveys are saying.
Right.
I never had, well, not never, but rarely would I have people identifying the need to talk about like the state of our country or the state of the world, and it feeling like it's encroaching on them.
Right.
Rather than a kind of shallow level venting thing, but that, that's not a useful amount of good use of our time in therapy. But at this point it is, because it actually is impacting people's level of stress and distress.
Right.
Yeah.
Yeah, I mean, for sure. I think there's, and I think this uncertainty in the world it's just so many factors. I think that sure, our political environment's been kind of a mess, but there's also, I think, just technology has the pros and the cons, and there's throughout history, there's obviously been advances that have sort of changed the world, and but I feel like they haven't been as dramatic as some of the technological things that we're looking at with social media and AI. Like, as I feel like they've been more dramatic and influenced us. And I feel like there was something else I was going to say too. I can't remember. But if you think of anything else,
I will.
That's a stressor.
But no, I think that point is well taken. It does feel like we're in the middle of this transition of this massive change.
Right.
Like right now I've definitely noted like a before and after AI, for example. Right.
Sure.
And you and I can both remember kind of a before and after of the internet.
Right.
One of
yes.
one of my favorite memories that I share with my children is when I was still in graduate school and I had a Mac computer on my desk. And I remember asking a friend of mine whose husband was in tech, like, okay, what do you mean by surf the internet? Like, I don't understand. And she said, you just go there. And I said, what do you mean go there? But I love that. I love that kind of capture of time.
Right.
And we know that things massively change then. It does feel like we're kind of in the middle of some sort of upheaval or change or something. And what the other side is, I don't know, but yeah.
Yeah, and I think that has, along with that, what is parallel is that we've maybe been, again, not everybody, but in some ways we've gotten further away from nature. In some ways we've gotten further away from our communities. Maybe religion was helpful to some people. Maybe civic organizations. And so, I think all of that is a little bit of a
I think that's actually a good segue maybe back to some of the survey data, actually, but a lot of the fueling factors to what we're talking about with depression, anxiety, and maybe trauma also.
Yeah.
That sense of disconnection, loneliness.
Yeah.
That's an epidemic right now, too. That's kind of a phrase I think that's being thrown in the news right now, this epidemic of loneliness.
Absolutely.
This devaluing, some intentional, some not intentional, of relationship, of this face-to-face sitting down together kind of thing. It was interesting. I think COVID actually highlighted some things that we may not have paid enough attention to if it had been more of a gradual evolution toward like virtual meetings and things like that.
Right.
That because we were all thrust into it so quickly and immediately, that we got the sense of what we were missing.
Yeah.
Right. And I don't know that would have come if we had just kind of, sort of gradually been in the pot of boiling water. Right.
Sure.
And so there is, hopefully we can harness that. Like, yes, we do need, there is some value in there's some energy difference, right? In sitting here together in these comfortable seats in the same space, right? Having this conversation, it would feel differently if you and I were on screens.
Sure.
Would we have a similar conversation? Probably, but would it feel fundamentally different? It would.
Absolutely.
And that's the stuff that I think has been impacting people because of that loss of presence and valuing that presence. And we can talk about adolescents being, I mean, they don't have any space to be kind of by themselves in solitude. They don't have space to be bored,
right.
and be able and to be able to know what, to get to know themselves, because it's just this immediate, and all of us are guilty of it to some degree, but this immediate ease of our phones and getting on that and texting and all of that, and it's all good stuff, and it can be good stuff, but it's also has a cost to it that I think we're living in now, and and I love your identification of nature. That is a set of studies too. The disconnection from nature, because that's a prescription, actually. I mean,
absolutely. Yeah.
For feeling more in your body, feeling more connected, even in solitude. Right. Yeah.
Right. Yeah. And I do want to talk about some of those, maybe your thoughts in a minute, how those types of therapies, like just getting in nature or exercise, like how that rivals some of the other things. But let's go ahead. Let's jump in a little bit to some of the therapies that you do that are, I think, pretty fascinating. And I know things like EMDR, and you can tell us exactly, I don't remember the whole, what the acronym means, but like, I know those things have been around for a while, but I feel like, again, the accessibility of them varies from maybe where you're living in the country. And yes, talk to us about some of those.
Okay. So I'm going to back up a little bit and talk about psychotherapy just in general, because all of these approaches they're approaches, just like talk therapy is an approach, which goes back to Freud and sort of before him a little bit, but he's sort of considered that's the first person who did psychoanalysis and this talking treatment thing. But we have to have this relationship with this other person. That's what good therapy is about, is being able to face our own struggles. So face them means kind of allowing them to be forward. So usually we move through the world with our best face forward in our best ways, and we try to hide the things that we don't want other people to see. And we do that because we have we're afraid of feeling vulnerable, of having, just feeling different, feeling less than, all of those kinds of things. Ironically, all of us are walking around with the exact same fears.
Right.
Okay. Looking great. Yeah, right. Everybody. That's what I remind people of, is that you move through your world, and I bet most people don't see what's happening inside. You look put together for the most part. Other people are in the same boat. You're not alone with that. So good psychotherapy, whatever it is about, that's the foundation, is having this person with, all the credentials or certifications on their walls and all of that good stuff. That's how you start trusting this person, right? Like, okay, they kind of know what they're doing, I hope, with these credentials. But then what's the experience in the room? The sense of confidence that you can be helped, that what's happening for you can be changed. And that sounds very basic, but that's one of the things that's undermined with depression, anxiety, trauma, like we're talking about, is that sense of agency, which just means that I have needs that are worthwhile needs. And I have within myself, within my system, plus around myself, I have what I need to get my needs met. That's what agency is.
Okay.
That's important in terms of a psychotherapeutic relationship, and having this professional across from you hold that confidence while you're not feeling confident at all about anything. Okay. So good talk therapy it's called interpersonal. So the clinician, so the therapist or the psychologist, the clinician is first understanding intrapersonal. That means inside this client that's here. Okay. So the intrapersonal are all the symptoms, all the struggles that led you to seek therapy.
Right.
And the clinician is hopefully skilled in understanding all of that and how that can go together.
Right.
Along with your current life experiences, your relationships, how you're functioning at work, how you're functioning at school, how you're functioning by yourself, all of that stuff. Plus all the experiences that you're bringing to the table and from your whole life. Okay. Sure. So you're taking the clinician is taking the intrapersonal, like what you're coming to work on, along with the interpersonal. That means the relationship between you. How are you able to sit with this clinician and share all of this? And then what are you doing with what the clinician's observing, reflecting, inviting you to do? And then some of those fears and defended kinds of responses, or almost I call it kind of a vomiting sometimes, like this, like it's just got to get all out here.
Right.
That whole thing. Okay.
You have to be able to trust to get all that out.
You do.
Yeah.
Right. And then, so then that's what you're building is trust. So what is this person, this clinician, how is this person seeing me now that they know all this dark stuff that I try really hard to keep hidden?
Right.
So fundamentally, what we're trying to do is create a sense of vulnerability and connecting that with a sense of safety. If you think about a lot of times when we're feeling really distressed, when we're feeling vulnerable, it does not feel safe at all.
Not at all.
To share, to be with yourself, right? With more extreme kinds of times, feeling vulnerable. And for a lot of people, that sense of vulnerability, like I'm exposed, is totally disconnected from any possibility of safety. There is no, if you're vulnerable, you will be hurt. There's no other reality.
Right.
Okay. So we're trying, that's actually, in any psychotherapy, that's the basis for, what happens when you are exposing all of this, and then you're met with compassion and loving kindness and acceptance and confidence and ease.
Yeah.
What happens with that? That's a sense of safety.
Okay.
Oh, I'm still the same person.
Yeah.
With all of this, I don't have, it's not, with the exception of this, I'm this person. It's all together. And so that's
kind of out. I'm still the same person. Nothing happened. The sky didn't fall.
Right. And this person is still right here with me in presence. Okay. So no matter what kind of therapy you're doing. Okay. So what kind of talk therapy you're doing, if it's predominantly focused on, the biggest therapy that people know of, and there's some reasons for that, is cognitive behavioral therapy. Okay. All that is cognitive behavioral components are part of any therapy. Okay. So cognitive behavioral therapy means understanding how our thoughts are connected to our behavior and being able to change our thoughts to change our behavior. Okay. That's what it is.
Yeah.
Okay. You actually have to have some amount of functionality in order to engage there.
Absolutely.
So just like we talked about before, if you could talk yourself out of in a consistent way, talk yourself out of your struggles, then I wouldn't have a job.
Right.
Okay. So
because most people would do it at home on their own, and they wouldn't take the time to go somewhere and pay the money and all that.
100%.
Yeah.
Okay. So, and I'm being a little bit simplistic here, but that's what gets in our way. So we have to understand what's interfering with us, not just knowing what to do, what's interfering with us doing the thing that we know we should do. So pretty much there are some skills that we can teach. I think that's one of the misconceptions of therapy too, that it's advice giving, which good therapy is not advice giving. But most of us know what we're supposed to do, right? I know that I feel a lot better when I go on my 30-minute walk every morning. Okay.
Sure.
Do I do that all the time?
Right. You don't always have
right?
time.
Sometimes you don't always have time, and then sometimes you have sort of a battle. And if you're feeling more distressed, the battle is higher inside, the conflict inside around doing what I know to do.
Right.
It's not about not knowing
Right.
that we're supposed to work out, we're supposed to go to bed early, we're supposed to, we're supposed to get off our screens. We know the things. It's not about not knowing it.
Yeah.
It's about, okay, I've got a part of me that knows this, that I need to get up and get out of bed and get ready for work. But when I'm feeling really depressed or really anxious, and that means just sort of heavy and unmotivated and low energy and feeling a sense of worthlessness and all of that, or feeling so much worry that you're paralyzed by that, overwhelmed.
You can't even, you can't do it.
When that's going on, it's not that you don't know that you're supposed to get out of bed. In fact, you're working with a part that's probably escalating in intensity.
Right. You're probably like chastising yourself.
Very much so. And even worse, right? It gets all the way sort of this, like a drill sergeant.
Right.
Like, get the F out of bed kind of thing.
Yeah.
Okay. So you have this knowledge, and then you have these competing ideas.
Yeah.
Just stay in bed. Just, you don't even deserve to get, there's nothing, it's too much.
Or it's too hard.
It's too hard. Doing that thing is not going to help you anyway. All these messages that you can call word symptoms of depression, right? No matter what you do, there's, or if you kind of a warning thing. I mean, there can be lots of things. If you get out of bed, then you have to face that, and then you have to face that, all that.
Right.
Kind of creating more overwhelm that leads to that entrenched pattern of, I cannot get out of bed in the morning.
Right.
Okay. So you've got to take all of this. You have to take, identifying the thoughts or the cognition, identifying the behavior that you want to change.
Yeah.
Okay. Whether that's, I want to do more of this thing. I want to make that easier to do, or I want to do less of this thing.
Right.
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 I want to make it harder to do. So some of the addiction kind of patterns that can come with that. So you have to take all of that, and I think respect and understand more about where it came from.
Okay.
And that's how we can engage with these cognitions. So it's not, we can do a change in behavior. Sometimes that accountability is a helpful thing, especially with more extreme presentations of depression. You do kind of have to join with a person where they are. So if having a goal of the number of times I brush my teeth every week is something like, I'm going from 0, which can happen with depression. All those daily living skills go out the window. You may have to start there with this basic behavioral stuff.
Right.
And then you can maybe, move up to the thinking. And then you understand, okay, what's underneath the thinking? What emotion is driving that? That, what are some of the reasons why this quote unquote part of you is saying to stay in bed?
Right. Yeah. So sometimes cognitive behavioral therapy is enough. And then some people, you need to go a little bit further with some of these other newer things.
Yes, in terms of sustaining it. Because the whole idea is we may not have internally, we may not have the resource to kind of get ourselves a plan and use the plan in a sustained way without that accountability on the outside. But the goal is, and my joke also is, my goal for being your psychologist is to get myself laid off. Right? Not needed anymore.
No,
eventually.
I think that's a great goal.
Right? that I'm wanting to help you strengthen your connection to your own resource that I believe is there even when you don't. And then be able to access that, be able to access the sense of what is interfering, being able to ask the questions, not just sit in self-criticism.
Right.
You're worthless.
Right.
But okay, so I'm not getting out of bed. What's going on here? Or I got drunk again last night. What's going on there? And to be able to do that internally, and that's mindful awareness actually is where you start with that sense of awareness of what kind, all these competing thoughts that actually can show up initially as quite a storm.
Right.
quite a thunderstorm. It's hard to disentangle and feels overwhelming in itself.
Yeah.
Yeah.
And so when do you go beyond that to something like EMDR or brain spotting? And how does it work?
Yeah. I'm realizing too, we didn't define depression, anxiety, and trauma, your earlier question. But so there are all of these approaches that I use that I've had extra training over my career to do.
Right.
Are called, it's a dual attunement model is really what is the common thread. Okay. So what that means, we talked about attachment earlier, and is the sense of attunement. So you think about tuning forks that come into resonance, or you might go back to those.
Tuning a piano?
Tuning a piano, sure. But you can also think of attunement like attachment. So you can kind of remember from maybe a class a long time ago about this parent and infant, right? Attunement happens at this level, right? Infants, what's their visual field is this length from this point in space to the mother's or parent's eyes here, caregiver's eyes. Attunement is the adult helping the infant's nervous system essentially be able to regulate itself. Right. So when we're trying to soothe, what are we doing? Okay. We're trying to help the nervous system come into some kind of ease, and we do that with our own ease. So those of us who've had young children know when we're feeling distressed, usually that's escalating, even though we might be saying all the right words, but our own bodies are there. So they're dual attunement models. So back to therapy. That means from the clinician, the psychologist or the therapist, to the client, the sense of ease, understanding, acceptance, presence, really. So attunement from me to the client to support and facilitate attunement from the client to all of their distress or all of their distressed parts of themselves, which we can talk about.
So like a string from one thing to the other.
Yes. So we're trying to support that sense of being able to be compassionate with yourself. That's kind of a shortcut answer there. And so with EMDR, which stands for Eye Movement Desensitization Reprocessing, Francine Shapiro, who was a wonderful psychologist who developed that method, wishes that she'd come up with a different name for it. People know that those words, but EMDR is more commonly known. Brain spotting is an offshoot of that. Both of them use the visual field in terms of accessing what the information inside your brain that you need to access. EMDR is a method, and it sounds really kooky until you've experienced it. And as a method that uses bilateral stimulation, that means that we have two halves of our brain, our right brain and our left brain. And we cross the midline with our eyes. So the clinician will sit across from you. And again, you got to suspend how crazy this sounds first, and then I'll explain it more. The clinician sits across from you and helps you with your, moving your eyes literally from right to left after you've identified, as you're activating whatever incident you need to act that is causing you distress. And then the clinician helps you move across left, right, left, right, left, right, while you've identified the visual image, which is such a prominent part of a traumatic experience often. That's what pops. We should probably, I might back up and talk about how you know what a traumatic memory is and how you know it's being stored as an unprocessed traumatic memory versus not a traumatic memory. But so we activate the visual image, we activate the belief about yourself, like I am unsafe, I am in danger, I am worthless, etc. You activate the emotions connected to that when you think about that memory. You identify fear or sadness or helplessness, that kind of stuff. You identify what you would prefer to believe about yourself. What do you hope to believe about yourself instead? I am safe. I am worthwhile. I have value. I am loved. I'm lovable, those kinds of things. Right. And you identify the level of distress. It's called a SUDS. Unit of distress is what it is. So 0 to 10, how upsetting or how much distress do you feel when you bring all of that stuff up, the visual, the emotion, the thought, and the beliefs about yourself. How distressing is that right now, 0 to 10? Or for some of my clients with more extreme experiences, 0 to 100 may fit better.
Yeah.
And then that's your anchor point. That's sort of the brief protocol you're anchoring. And then you do those weird eye movements. And what the model is called is an AIP. It's Adaptive Information Processing.
Okay.
So this goes for actually really all the models, but Brainspotting and EMDR, where you're helping the brain not just kind of spin around in that traumatic, helpless frozenness of the memory, but you're helping to help connect up more adaptive information. So that may be that even differentiating that I am in my present moment. It is not happening right now.
Okay.
So with the combat veterans, for example, a car backfiring, right? That isn't dangerous in the moment.
Right.
Right. But it reminds the nervous system of when it really was dangerous. And when you're in a post-traumatic distress kind of brain, there is no difference.
Right.
And so your entire nervous system reacts just like it is. So one of the analogies I use, it's helpful, I think, is if you're hiking in the woods, to go back to nature, you're hiking in the woods and you come across a bear, what are you going to do? Your nervous system is going to activate.
Sort of, yeah.
You're basically you're gonna fight, hopefully not fight back, but that's what you're readying yourself for.
Yeah.
You're startled on purpose, right? This is actual danger. So the bear is actually dangerous to my physical body. Okay. If I, for some reason, sit there and notice, oh, that's not a bear. That's a cardboard cutout of a bear.
Okay. Yeah.
It's just cardboard. It's sitting there.
Yeah.
Is the cardboard cutout dangerous to me?
No.
Has it ever been dangerous to me? No. But our nervous system a moment ago, it didn't differentiate that. Right? And so a post-trauma presentation can be like, even if a part of you kind of knows that it's a cardboard cutout, you just can't stop that cycle of it's dangerous, it's dangerous, it's dangerous.
Yeah.
You can't get your sympathetic nervous system to come back down on the other side.
Right.
You can't activate that parasympathetic nervous system to get you back to kind of a baseline. And so, so that's what we're trying to do is help to differentiate. This is a memory. That's really hard. This is a memory. This can't hurt you anymore. Because what's happening internally is that the memory reminds you of every time it gets generated, because it's so vivid, which it reminds you of the reality or the experience so much that your brain is not, it's too stuck. So if we kind of define traumatic memory, how we know, and we all have what's called sort of little T traumas and bigger T traumas.
Sure.
So big T traumas are the ones that are sort of more obvious, and little T traumas are things that may have overwhelmed us at the time of our lives, and they've accumulated, but each one doesn't seem that distressing, especially to an adult perspective.
Gotcha.
Okay.
Like maybe you're bullied as a kid.
Absolutely.
And like later you didn't get a job that you wanted, or I don't know.
Right.
Like,
yeah. So overwhelmed your coping resources at the time of the event. When you have a trauma memory, and you don't have to share it, but if you have something that was upsetting to you even, the whole thing pops out at you, right? The visual happens, your stomach might kind of clench up,
right?
Or you might get some tingling or numbness. You might have your head might tense. All these different things can happen. You may have a brief spurt of emotion or startle when you think about a distressing event that happened a long time ago, okay? That means that more of our brain systems are activated. Our our amygdala is being activated there, right? That's what all that startle is about. All of our sympathetic nervous system, our autonomic nervous system is being activated when we're just pulling up a memory that was distressing. if I asked you what you had for dinner last night, assuming that your dinner was not a traumatic event, you kind of go to your file cabinet and you look for what happened at dinner. And there's no pop. There's just a file cabinet that you go to. And then you're like, oh, yeah, I had soup last night. That's not a traumatic memory. And that indicates that it's it's already been processed. Your hippocampus has already helped process that. It's now a story. It's a narrative, beginning, middle, and an end.
Yeah.
There's not an emotional sort of shock.
Yeah.
Right. So that's what we're working with. Right. And we're actually with the research, what's interesting, when you have successfully processed trauma memories, the brain lights up differently. Okay. It's more of a file cabinet kind of experience. Okay. That's the goal. Yeah. There are certainly extreme traumatic memories that are not entirely going to be out of that thing. But the more you build with that grounding, like, this is not happening now. This is not hurting me anymore. Right. Yeah. Then you have less and less of that reactivity.
How does and you can tell me about brain spotting too, but how does the thing where you're moving your eyes back and forth, how does that help people do that?
Yeah. What's fascinating to me is that the research is still being done right now, even to know, because this is one of those things, both, there is a lot of research behind it. That's what's really cool, that it works. Yeah. But essentially we've got our left side of our brain, our right side of our brain. Okay. Our left side of our brain is more of that planning, thinking. Actually, that's the one that kind of calms things. Okay. And our right side of the brain is more of that emotional. This is a very basic kind of thing, but more emotional kind of stuff that gets pulled, and it's less. So that's what it is. It's kind of that logical activation of emotional. Yeah, but it's it's got its own logic to it in terms of its emotional center. And so basically it's activating both of those things back and forth. Yeah. Okay. There's a really wonderful kind of older TED Talk that this neuropsychologist had a stroke. And it's called a stroke. I think it's called a stroke of genius. I think that's the name of it. Yeah. But she had a stroke, and then she did a TED Talk because she's a neuropsychologist on what her experience was, and she was going back and forth from the left side of her brain being able to phone for help, and her right side of her brain was just sort of out in space, just kind of out there. But it's just wonderful, like, flow back and forth. But so they're looking for EMDR. That's what the theory is, but it's like how EMDR is helping you access adaptive information, right? Reinforcing all the ways that I am strong, all the ways that I have value. That's what sort of comes up eventually. So initially when you're doing the eye movements, it's all the trauma and stress. And then what starts happening is kind of what's kind of floats up into your consciousness, and what gets spoken out loud is suddenly like more adaptive kinds of statements. And that's what you're trying to connect those up. And so that's the theory with that.
Because you're accessing both parts of the brain. It's allowing you to not just like do the spiral thing with whatever your trauma was, but it's allowing you to look at it more logically. Yes,
it's actually allowing that to be connected up. The planning, the thinking part of your brain gets disconnected. Again, very crude terminology here, but disconnected when a trauma memory is activated. Okay. It can't talk itself out once it's kind of really going, right? Once it's overactivating and dysregulated. Right. And so what you got to have some kind of in between. So in meditation language, that's the noticing brain. It's not the thinking, planning, logical, like, this is what makes sense. Right? We all experience that. Stop being ridiculous. That's one of mine, right? Stop being ridiculous. No, you've got to have some kind of other state, the noticing brain, that helps connect up that thinking, logical brain to calm down that overactivated stuff. That's what it's doing. Brain spotting is an offshoot of EMDR. So it was developed by Dr. David Grand, who was an EMDR trainer, and actually, and that uses gaze points. Again, this sounds so crazy. It sounds really crazy, and then you do it, and it's like, oh my goodness.
Yeah.
But and there's again good research behind it. But he was doing those eye passes, right? Those back and forth, left, right. He's actually working. There's a whole story there, but he was working with highly competitive sports or athletes.
Okay.
And what he noticed was all this kind of all this autonomic activity going on when he hit a particular point when they were going with eye blinks and, I mean, all these things, different changes in breathing. You're paying attention to things like pressing your lips together or swallowing, that kind of, all these autonomic nervous system things that mean that you're activating that kind of part of your brain. But the gaze point, where you look affects how you feel. And it's accessing, so you identify that very natural, we're harnessing something that does make sense. It doesn't sound crazy at all. As I'm talking right now, as you're talking, your eyes sort of drift up, drift back, that kind of very natural process. If you asked me to solve a math problem right now, I'd probably do some kind of squint and focus thing, okay? Like that. It's sort of gathering information and helping concentrate something, right? It's hitting, and our visual system is directly connected to those parts of our brain. So it's harnessing that. It's harnessing the sense of having a gaze point that connects to traumatic material or connects to adaptive material. Again, this resource calming kind of place in order to access this in a grounded way.
All right.
Okay. So instead of doing this eye passes left, right, now we're doing that same protocol I just went through, where you're identifying what memory do you want to work on, what's kind of popping out or causing distress. And then the clinician will help you identify what that is, or where the most activation is.
Okay.
By starting, you have this pointer thing to kind of start going all the way across, and you start at one point, one axis, and go across. And it's really strange when you can do that right now. When you're accessing a memory and you have a certain level of distress about it, it's a 5.
Right.
And you can find a point that level of distress goes up or goes down.
Like when you're telling somebody with a pointer, look here, look here, look here.
You're kind of going all the way across. I'm looking also. I'm looking for all these signals that I'm paying attention to with breathing and that kind of thing. But also just your own, like that 0 to 10 thing is a set subjective units of distress, which is, but it's, what does the person notice? Okay. And so it's like, okay, hold that memory. And then you're going slowly and you're tracking with your eyes this way, you're tracking with your eyes this way.
Sure.
Sometimes let's go to the Z axis right this way. Okay. Yeah. And then you hold that point. Or you can also access, okay, that's like goes to an 11. It's just too much. You can, you don't ever have to hold anything. That's one of the invitations. But you can also access resource that way too. Where's the place that feels calm or grounded, at ease or peaceful?
Does that mean you would have to move your point so they can access that?
Sometimes, yeah. Okay. Or, as you're kind of moving through, a lot of times the experience is, that feels better. I don't even understand why, whole thing. But then we can come back to that, or they can process from there because it's already got some kind of adaptive information connected to it. So you can access from there. But the whole thing with, these two kinds of processing therapies is, and we haven't really talked about my base of psychotherapy, which is an ego states model, like you were talking, like with hear me talk throughout about parts of us. So being able to invite whatever needs to come up, the good, the bad, and the ugly, everything is able to be tolerated and engaged with and unwound. You used that word earlier, which is exactly the word that I use, because it does feel like it's a tangled up ball of yarn. That's one of the things, and you have to follow the natural process that our nervous system, it's wound itself up.
Right.
It has a way of unwinding, but we have to follow it.
Mm-hmm.
So that's the other probably foundation for the kind of therapies that I do, is that my presumption is that of natural healing, that our systems know what to do, right? We have to follow, it's a tangled up ball of yarn analogy. We have to follow the yarn, and it does unwind. It's got its own coherence, and we have to, that us following the yarn and pausing, if we hit a knot, we need to sit there and disentangle that first, right?
Right.
If we do that and we're like, oh, that's it, that's where I really need to go, and we dive through the ball of yarn, what happens? Usually we make it worse, right? We gotta make it tighter.
Right. Initially, you maybe make it, the person is going to have like a reaction.
Yeah, of course.
Yeah.
So, but that's what I talk about too. Our nervous systems are designed, just like the rest of our body, to know what to do and to heal themselves. So if I cut my finger, you might be able to explain what's happening to heal my finger, but I don't have to understand that even.
Right.
I have to take care of it and maybe get the barriers out of the way.
Yeah.
And it might need some support. Your finger might need some support to heal. So it might need a Band-Aid, it might need stitches, it might need an antibiotic if something's interfering with that. And those are the tools we can use. But the best bet is to allow our body systems to heal as they know to heal.
Yeah.
Okay.
Well, okay. So just thinking about what you were saying. So during these sessions, you're harnessing some of these memories. So is it something where you may have to take a pause and say, okay, we're going to come back to this next week? Like how many sessions does this usually take?
Yeah. And that's going to really depend on, for some people, it can be a very long process. Sort of the more, I work with a lot of people who have complex trauma, complex developmental trauma, which means an accumulation of really bad things that happened to them, and a lot of things that should have happened for them that did not. So that's a definition of complex trauma.
Right.
Okay. So the things that happen to people are things that we understand, abuse kinds of situations, sexual abuse and physical abuse.
Sure.
The things that did not happen for them that should have are things like care and nurturing, protection from being exposed to violence,
Right.
Neglect of emotional and physical needs, those kinds of things. And that's what we've learned again over the last, decade or so.
Right.
How much the lack of the things that the lack of needs being met, like that neglect piece,
Right.
or the failure to protect, impacts the brain, and it's a traumatized brain too.
Yeah.
If you kind of hit a particular threshold.
Yeah.
Right.
All right. Well, because I know we wanted to discuss just a couple of other things, and let's talk a little bit about your work with yoga, and then there was the other one with the developmental needs.
Sure. So developmental needs meeting strategy is one of the ego states models that I use. I probably would say there's another ego states model that's probably more of my foundation, which is called internal family systems. So the idea that the idea that it's not a family of origin idea. It's more the idea that inside ourselves we have kind of this system of parts that work together.
Yeah.
That we have a centered self. And that's true for both of those models. And that's the place of ease and kind of where we get all our resources.
Right.
Right. Okay. That's what we access when we're feeling, calm, confident, playful, creative.
Right. All the good stuff.
All the good stuff. And then we have these parts of us. Some parts hold pain.
Sure.
And some parts try to protect us from that pain. And we just think about, just like the examples from earlier, it's very accessible. We all have parts. That's one of the things when I work, people say, does that mean I've got this? And no, we all have that. It makes better sense, right? It makes better sense to say a part of me wants to make sure that I go exercise every morning, and then another part of me maybe wants to sleep in, versus I want to sleep in, I want to exercise. Like that. right? I want to drink. I don't want to drink. Like
Right.
that
Right.
doesn't feel as coherent, but it's just very easy. It's very natural. And so what we do is we approach these parts, this person, and approach the part that is creating the problem or presumably creating the problem. Oftentimes what we think about when we're looking at this as it's an adaptive functioning model.
Yeah.
So all the models I use are adaptive functioning, meaning even very extreme kinds of presentations are the result of adapting to circumstance, adapting to experience. Okay. So throwing yourself, if a car backfires, throwing yourself, throwing yourself over the top of a person on the sidewalk,
Right.
that doesn't sound adaptive at all, right? But if and that looks crazy, that doesn't match the situation, right? The backfiring of a car doesn't hurt anybody.
Right.
But if we think about it from this approach and like out of curiosity, right? If we are curious, what led to that? What were you afraid of happening if you didn't come over that person? Then all of a sudden we get, well, they would have gotten hurt because this is what happened. This is what happened for such a long time that's just the normal pattern. That is the easier thing to predict now.
Right.
That with this loud noise always is danger.
Right.
And that pattern sustained for this much time.
Okay.
And so that's what we're having to unwind. But we approach it with curiosity and we kind of have this little dialogue with our parts.
Right.
Right. And then we kind of help the part to feel seen and respected, just like we help the person feel seen and respected.
Yeah.
And it feels a little kind of kooky initially.
Okay.
But we talk to ourselves all the time.
Yeah.
Right. And we're just, again, harnessing what we naturally do. But the clinician who is trained in these ego states models is helping to stay grounded and open and accepting, and then engendering that in the client, because we are not often any of those things when we're frustrated with parts of us who are causing problems.
Right. So you're just helping that person to connect with those parts and recognize that not all of it is logical or is a danger or.
Right. But first, before we talk them out of that, we have to, just like, we have to respect what was their experience that led them to this.
Sure.
That makes sense? Like what was adaptive at one point?
Yeah.
Right.
Yeah.
So something that was very adaptive in the past and vital to survival even.
Yeah.
Right now is actually having too much of a cost.
Right.
So that can go actually for total withdrawal and avoidance. That may work to keep you safe, for example, but how much of a cost is that now?
Yeah.
To sustain it.
Yeah.
And what are you losing by sustaining that kind of way of approaching your relationships or yourself? Yeah.
Is there anything you want to say about the yoga piece?
Oh, the yoga piece.
I mean, I love yoga just generally. I think it's a great tool.
It is.
In your toolkit.
So the very clunky wording, and I'll tell you why it's that. But it's trauma center, trauma sensitive yoga. The reason it's trauma center is that's a giant center. It's actually that's where all the research happened.
Okay.
If I say Bessel van der Kolk is kind of a prominent name.
Okay.
The Body Keeps the Score is the book that it's almost mainstream at this point about trauma. But he really is one of the pioneers to transform how he was working with veterans with PTSD and how that you have to access the body. You cannot ignore all of that going on, all that activation in order. Talk therapy is not enough to get there.
Tell us again the name of the book and the author.
The Body Keeps the Score, Bessel van der Kolk.
Okay.
Kolk. Okay. So the Trauma Center, there are lots of very prominent clinicians out of that. One of my favorite trauma psychologists is Janina Fisher, also out of Trauma Center. So that's why that is in the name of the yoga.
Sure.
But it's in Boston and in Massachusetts. So they started looking at how yoga could be used initially as an adjunctive tool to trauma survivors.
Yeah.
Okay. And then they started doing systematic research on it, which was wonderful. And that was the first National Institute of Health grant to study yoga and its impact. And they've had really wonderful results. And over time, that has included, and this is really important, included feedback from clients themselves to adapt, Western style yoga to what is going to support a traumatized system, right? Best to as an embodied practice. That's what it's called. And so it's an adapted kind of approach. And so that's what I've got a 300-hour certification in over time, which was really wonderful. But it employs different tenets of yoga. So it uses a non-harming, so that's out of yoga, non-harming, it's non-coercive, okay? It's a lot of choice built. It includes choice of what you're doing. Okay. Now, those two, and it's a shared experience. So traditional yoga is, which I do all the time, and I love, but traditional yoga is an instructor kind of in the front of the class, right, telling me and directing me what to do with my body. There is an implied right or wrong, right? So even as, this is your practice kind of language, right? We all, that I smile, but, we're trying to look like that picture. Right. And it's okay if you don't, but that's really what you're going for. That's the implied message. Okay. So all of a sudden we've almost got a reenactment of something. We have this person telling me what to do with my body, and it's and what to do with my body. This form has to do with something external to my own experience of this. So even if my body is signaling that it doesn't want to go that way, I might try to override my own experience of what my body is telling me in order to access that externally driven form. Okay. Yeah. So it's very directive, place your right foot here, place your left foot here, place your arms here, Okay. Now, with trauma-sensitive yoga, everything now becomes a choice, which actually can be hard. Everything becomes non-coercive. So you shift your language to, rather than take your right foot and place it here, it's you may be interested in, it's a little repetitive kind of, and it's invitational language. So if you like, you might choose to join me in moving back and forth. You're welcome to stay still. There's always that option. You're always welcome to introduce movement into a form that I might cue as stillness, or into a form that I might cue as still form. Right. You're welcome to make any change that you like. So what you're trying to do is help the person not dissociate from your body and just follow the instructions, which can feel soothing too, right? Sure. To sort of disconnect. But that's working to unwind the trauma by encouraging a sense of is this body safe to pay attention to? Okay.
Safe to make your own decisions?
Safe to make your own decisions. Okay. So if you think about certain kinds of traumatic experiences, especially developmental trauma, which means kind of in the course of a relationship having bad things happen to you inside of a relationship. Now and it might be better after a while of being harmed in your body to simply disconnect, to dissociate. That's actually an adaptive. Absolutely. Right? It's an adaptive decision, essentially. And so now we're introducing this embodied experience of safety here, right? But you don't have to connect with. You may notice that you're breathing, right? Just these little tiny cues. You may not. You may notice the surface beneath your foot, leaving room for the possibility of not noticing much sensation at all. So that's non-coercive, meaning if you don't have a sense of your own body, but somebody's cueing you to pay attention to the sense of your body. That's a really subtle way of like, you're in the wrong again. You're a freak again.
Right.
And so that's the framework of it's called TCTSY. Yeah.
So do you do that like with just a one-on-one with patients, or do they usually do it in a group?
Both. So I do, even with one-on-one, it can be a really helpful thing sometimes to bridge into a session to kind of ground.
Yeah.
Even the sense of making a choice, right? So if I'm making a movement, if I'm raising my arms and lowering my arms, this is a sense of like, this is what I'm supposed to do, right? So the experience one-on-one of what happens if I don't raise and lower my arms like Katie's doing?
Right.
What happens?
Right.
In my nervous system, with certain kinds of, especially sexual trauma, if I make a choice, that can really have disastrous consequences. So it's really better not to make a choice.
Right.
And my only cues might be what they're doing, like the external, right? Okay, if I'm doing what she's doing, this is safe. This is a safe choice. But what happens if I don't? Well, guess what? What happens? Nothing. I'm still safe.
Yeah. Yeah.
And so that's this small and big embodied experience. But what's really cool is that they actually just had in 22, they published a study with the military through Emory University, and they showed some very good effectiveness and comparable to another kind of talk therapy that's recommended by APA. It's in the guidelines for PTSD, and they did a randomized controlled trial with TCTSY, and they had some really good results with some military sexual trauma, actually, with this group of women. So anyway, there we go.
Wow, we could. We'll have to have you back. We could talk all day about this stuff. I find it so fascinating. Well, thank you, Dr. McBride, for being here with us today.
This was my pleasure. I hope it went well. I know we sort of rambled around a bit, but I hope it was enough. Yeah,
I think it was great.
Okay.
I just, like I said, we could talk for another hour. I have so many questions. But again, we just really appreciate educated guests like yourself who bring us this, all this knowledge about these important topics.
Oh, my pleasure.
And thank you, listener, for being here with us today. And I'm going to guess if you stuck around to the end, mental health is something that's important to you. Share the episode with your friend. We really appreciate each and every one of you. I am on YouTube, Spotify, TikTok, and Instagram. On YouTube, you know the drill. Please subscribe to the channel, like the video. Guys, again, I hope you have a great week. Thank you so much, and we'll see you soon.